Hey, everybody. We're going to get started in just a second. I just want to welcome you to the 2023 ENI Exchange. We're happy to have this in person again after being virtual for the past 4 years or so. And so to get things started, we are going to kick it to our keynote speaker. This is Mario Prohaski. He is the Director of Life Sciences Consulting at Baker Tilly. So kick it off to Mario. Thanks.
Thanks, Erin, for the introduction, and good afternoon to everyone in Chapel Hill. I'm really excited to be with you this afternoon. Although I must admit, I am disappointed that I'm not able to join you guys in person this afternoon. I have very fond memories of Chapel Hill, and especially springtime in Chapel Hill. But I'm hoping that despite the virtual nature of this discussion, we'll hopefully have a fairly interactive conversation with regards to some of the key trends and issues that we see in relation to governance and responsible governance in ESG in the healthcare industry. So really looking forward to it and getting this conversation started, and of course participating in this afternoon's summit. So I'll briefly share my screen, and I hope everyone can see it shortly. Can everyone see the screen?
Yes.
Okay, perfect. So what I was hoping to cover this afternoon is start off with a brief introduction of myself and maybe some of the background that I have on the topic of ESG and governance in particular. I also will be upfront in sharing with you that my perspective and my experience is largely focused on the life sciences industry. And I do certainly hope that through some of the additional panelists this afternoon, you'll be able to get a broader perspective into other aspects of healthcare, into the payer and provider space as well. My focus on today's presentation is really going to be on life sciences, where most of my perspective sits, but hopefully, obviously, this will tie in well with some of the other panel discussions that will be taking place this afternoon. So with that in mind, I was hoping to spend a little bit of time just giving everyone a brief kind of overview of what I see some of the key trends and strategic developments in life sciences, and then transition into talking about how responsible governance is driven in the life sciences industry, and maybe what are some of the key considerations and best practices that we see here at Baker Tilly, and obviously through my own personal experience in life sciences. And lastly, I'll try to close with a couple of thoughts on how governance from an ESG perspective can also serve, I think, as a useful tool in driving the overall strategy of a life sciences organization and mitigating risk at an enterprise level as well. But just to get us started, so brief introduction of myself and my background. So I graduated from Kenan-Flagler in 2011 with my MBA, and have been really for the past 12, 13 years in various roles in consulting and advisory services focused on life sciences. You'll see some of the companies that I've worked with in the past on the right. So I actually started my post-business school career with a company called Polaris Management Partners, an organization that was very much focused on risk and governance and compliance issues and projects for the life sciences industry. We were able to grow Polaris eventually to a point where the company was actually acquired by IQVIA. And IQVIA, for those of you who may not know, is a large healthcare conglomerate focused on data, technology, and services. That's what also gave me the opportunity to spend some time in Europe. I led the European commercial compliance practice for IQVIA for a few years in London, and then relocated back to the US in 2022, eventually joining Baker Tilly, now in a role, again, focused on life sciences advisory services within Baker Tilly, with a focus on risk, compliance, as well as some other topics related to medical affairs and market access as well. So very much focused background on advisory services in the life sciences industry for the last 10, 12 years. On a personal level, I'm from Bulgaria originally, and have spent really most of my professional life kind of moving between Europe and the US after a few years in North Carolina, New York with Polaris, then London, and then now back here in the US in Philly. So very much looking forward to continuing our discussion. And of course, if there's any questions, feel free to kind of raise your hand, and maybe we can engage in discussion throughout the presentation. I'll also make sure to leave a few minutes at the end for some Q&A as well. So just to get us started, I wanted to give maybe everyone a little bit of perspective on what I see as some of the key trends in the life sciences industry in 2023, and how that maybe is changing a little bit, or as compared to some of the key issues that we've experienced in the industry, kind of leading up to COVID and obviously during COVID. I think first and foremost, there's a very, very strong focus on really what I'll call having a patient-centric attitude to the life sciences business, probably even more so than before the pandemic began, with a strong focus on issues around global patient engagement, patient equity, access to medicine. All of these, I think, are topics that I think will be covered in some of the panels later this afternoon, more from the social side of ESG. But I think they're very critical for the strategic growth of the life sciences industry globally. Secondly, the way life sciences companies are engaging with customers, and when I mean customers, I'm really talking about patients as well as healthcare professionals primarily, is changing as well. I think we're moving to a much more kind of technology and data-driven way of engaging with our customer base, where there's a proliferation of channels of engagement as well, with its own kind of strategic and compliance challenges. And that's more and more replacing kind of the more traditional kind of face-to-face type interaction, particularly in terms of engaging our customers in the healthcare professional community. ESG in itself, I think, is also a trend that we see in the industry as something that is no longer a kind of a buzzword, and it's becoming more and more of a strategic imperative in life sciences. I'd say the industry itself may be a little bit late to the game, maybe compared to some other industries, but from our perspective, I think there is definitely a huge focus, particularly on the social and environmental aspects of ESG in life sciences as well. And I'll talk a little bit how governance also obviously fits into that component as well. Lastly, compliance and compliance programs, calibration in life sciences is also, I think, a key trend. From our perspective, the industry remains heavily regulated in all of the major markets. So the compliance and regulatory scrutiny remains quite high, and probably will continue to do so, especially with some of the key pressures around pricing and drug approval processes that we see here in the US and some of the other developed markets. So what we have, I think, is a situation where the industry is facing kind of an interesting dichotomy. On the one hand, the life sciences industry continues to grow. There's huge innovation happening. The market growth is quite extensive, and that really didn't stop during COVID. In fact, it sort of continued and maybe in some ways even accelerated during COVID. We continue to see great success stories in a lot of disease areas, with the introduction, of course, of the COVID vaccines program, with headway in some key disease areas like Alzheimer's and oncology. So that's, I think, kind of undoubtedly a success story, and shows the positive impact of our industry, in addition to the continuous kind of commercial growth. Yet, on the other hand, there's in many ways, particularly in the developed markets, particularly in the US and in Europe, I think a continuous lack of public trust and a relatively negative perception of life sciences and the pharmaceutical industry in particular amongst the general public. There's obviously a lot of questions around drug pricing, around drug pricing profiteering, around corruption in the life sciences industry. So one of the things that I'm hoping to convey through this presentation is I think it's as ESG programs become more established, and as we put in the right governance in order to create and mature our ESG programs, that will hopefully, from my perspective, help to sort of close the gap between that sort of negative public perception of life sciences on the one hand, and I think the tremendous success stories and growth that we've seen across the industry. But the industry doesn't exist. Our industry doesn't exist in a vacuum. Obviously, there's a lot of changes that are happening also in other parts of the healthcare kind of universe that are impacting the life sciences industry. There's changes in technology, and I think really moving into a much more data-driven approach to drug development, to customer interactions with healthcare professionals and others. And I think that's still going to be, an accelerated trend. We're seeing AI being used more and more actively in the life sciences industry as well. And I think this is just the beginning, I think, of a lot of changes driven by technology. But also what we see is the structure of the medical profession is changing as well, right? So there's more and more pressure on the time of physicians, in order for them to fulfill their patient obligations, which in turn makes their interactions with life sciences even more challenging, right? So you have to be able to convey continuously the right messaging through the right channel in a way that physicians are receptive to. And ESG, again, can play a role in some ways in terms of enhancing that customer relationship because our customers, patients, healthcare professionals, etc., I think are more likely to engage with companies that are acting responsibly, that do have the right ESG practices in place. And that can be a differentiating factor for a lot of life sciences organizations. And then lastly, I think we're going to continue to see a focus on specialty products. So the focus there being on products that are that may target a very specific patient population that also require significant upfront investment, but also have tremendous commercial potential. By some estimates, I think, depending on the disease area, you're looking at least $1 billion to up to $3 billion of investment required to bring a drug to the market. And then only 1 out of 10 research compounds in clinical trials reach the product approval stage. And that doesn't even include all of the research that is preclinical that takes place as well. So I think the barrier to entry, is going to remain quite high due to the focus on specialty products. But so is the reward for those companies that do make that jump into the commercial space. So what does that mean from to transition our conversation into some of the key drivers that I see for responsible governance in the context of developing ESG programs in life sciences. So I kind of think of those as sort of 3 foundational types of drivers for responsible governance. So first and foremost, we have making sure that through establishing the right governance, you're driving an effective ESG program. And there's, in order to make sure that you have the right, you're able to track and report on the right KPIs and fulfill your reporting obligations. So getting that governance right, and I'll talk a little bit more about that, is critical to the success of the ESG program in the first place. Secondly, there's a lot of internal pressure from employees in particular to establish the right ESG practices and to have good governance of an ESG program. I think that's really an employee retention and a talent management expectation that is continuing to grow in life sciences. And then lastly, external pressures, right? As I mentioned, from customers, those being healthcare professionals or patients, but also from investors. I think with some of the recent trends in the financial markets, access to unique sources of funding that are predicated on having good ESG programs and appropriate governance of those programs is going to become even more critical, particularly for those early stage companies that are looking for very significant amounts of upfront investment to even get into the clinic and then proceed with their research. And if I kind of focus a little more on the actual kind of core components of an ESG program's governance and how we make sure that through responsible governance, we are also implementing the right ESG and the most mature ESG programs within the life sciences companies. I think it's important to know that the governance framework obviously does not exist in a vacuum. It needs to be right-sized in terms of the level of responsibility of the various functions versus corporate, in terms of the level of formality of ESG governance internally. There's different schools of thought there that I'll get into shortly, but it needs to be the right size, and companies will need to answer more and more the questions of what's corporate versus functional ownership. Where do I need to have the right ESG champions internally? And also, where does the oversight from the board reside? Does it reside with the full board, or is it more differentiated and maybe certain topics or certain aspects of ESG are only under the preview of specific committees of the board? And what's equally important is to make sure that you don't stop just with establishing some level of ESG governance. There's a lot of things that need to happen in terms of relationship building, in terms of kind of building partnerships across the organization that are necessary in order for companies to be able to appropriately track their ESG footprint, KPIs, and then obviously have the right kind of reporting mechanisms in place. So I think there's almost kind of the formal governance side of things, but equally importantly, you have to have a very strong informal processes in place that connect all of the key functions to whoever is owning the ESG program at a life sciences organization. And that's no different in my mind than how some of the other compliance reporting requirements in life sciences have had to evolve. And I'll speak a little bit about one of them shortly, but it's that sort of combination of formal governance as well as a lot of informal relationship building that needs to occur for companies to be able to fulfill their obligations appropriately. And you see here on this next slide how the sort of the breadth of the impact of an ESG program within life sciences. So on the left side, you have the key kind of reporting components that are expected in a life sciences organization, and that's not necessarily an exhaustive list here, but anything ranging from access to medicines, clinical trial diversity and the representation of underserved populations in the clinical trials, all the way to the overall products, the safety of your products, your supply chain quality, as well as issues around pricing and how you market your products, to physicians and other stakeholders. Just that scope of reporting obligations means that they touch on pretty much every major function within a life sciences organization, from clinical and R&D all the way to commercial and market access and all of the other kind of operational functions in between. So how you structure your program is really going to be driven by some formal governance, but also a lot of kind of relationship building and connection that needs to be established with those respective functions as well. And then we also have to ask ourselves, what does good governance of an ESG program actually look like in a life sciences context? And as I was thinking about this in preparation for today's meeting, I actually struggled to identify necessarily a one-size-fits-all best practice. And I think there's a couple of reasons for that. One is obviously the fact that ESG as an area of governance within a company, in a life sciences company, is still new and evolving. And then secondly, obviously, you have the industry is quite diverse. So, what good governance may look like for a top 5 or 10 pharmaceutical manufacturer of the likes of Gilead or Pfizer or AstraZeneca may be very different than what that should look like for a company that is just entering the clinic and it may still be 2 or 3 years away from being commercial. But there's some trends that I think that we can try to discern in terms of some of the key areas of governance around board oversight, around functional ownership and reporting structures, and then some of those internal collaborations that I was referring to. So generally speaking, board oversight is in some of the key topics related to ESG is provided by the full board. And that includes areas around kind of DEI initiatives, corporate culture, and generally anything that has to do with regulatory and risk and compliance matters. Now, other topics, and this is where things get more interesting, are perhaps kind of delineated further by committee or committee representation of the board. And here's where you have a lot more variability, I think, depending on the maturity and kind of the level of evolution of each company. The functional side is also quite interesting. So in my experience, there isn't really one function within life sciences that owns ESG governance. It tends to default to legal and compliance in probably the number of organizations that I have worked with, particularly in emerging pharma, where you may not have a lot of other kind of corporate functions established. But that's not necessarily always the case. Or in large organizations, you see a kind of a more diffuse ownership between legal and compliance and some corporate functions like the office of the CEO or other similar functions as well. And the same thing, not just in terms of the actual kind of ownership, but the ultimate reporting. It is often confined up through the legal function, but that's not always the case as well. So it will be interesting to see as governance of ESG kind of becomes more established, how that will also shift in terms of who owns that within a life sciences organization, and also how the way the board provides oversight may shift and change in the coming years as well. And to me, that evolution or some of these trends are not surprising. I think, as I alluded to earlier, I see a lot of similarity between how governance in an ESG context is being developed in life sciences now to what was happening maybe 5-10 years ago with the establishment of some of the initial kind of other compliance reporting requirements that are now central to the operations of a life sciences company. So take one example, there are, one of the key commercial compliance requirements is what's called transparency reporting. This essentially obligates pharmaceutical companies to disclose their interactions with healthcare professionals, particularly for promotional and advertising purposes, both in the US and started in the US, and now it's become a global trend in over 50 countries. And initially, there was really no governance of this type of reporting when the initial kind of Federal Sunshine Act was passed in 2012. Eventually, I think what we started to see was, and kind of some of the key lessons learned around that are that companies began to establish scalable governance on this, and I think that's something that we need to be thinking about from an ESG context as well. And then that scalability had to be had to be developed on the fly, right? So I think initially this was thought to be only a US concern. It grew to be a global reporting requirement, which required companies to then really sort of double down in terms of building even more processes and infrastructure. The second kind of key lesson word was the need for shared ownership. And this is something that was something initially very purely as a compliance reporting requirement, right? But what companies found out pretty quickly was that in order to fulfill that requirement well and be compliant, they really had to build a lot of internal connectivity to the business functions where that data was being generated. So particularly in the commercial and medical space. And to me, that's no different to now us making sure that, we need to have the right kind of connection and relationships with our patient engagement teams, with our clinical teams, with our commercial teams in order to comply with or fulfill our ESG obligations as well. And then the last lesson was also one of sort of process versus systems. Early on when transparency was introduced, there was the temptation to say, an automated solution is going to solve this problem, right? So we'll just, purchase the right kind of solution, and then we'll just feed the data into that and then report. But what companies realized that, at first, probably the focus should be more on optimizing your process to make sure that you have the right data collection mechanisms and also the right reporting kind of structure before automating. And I see, I could see this sort of playing out in an ESG context as well, where, as more reporting requirements are being introduced, and we see it now in countries in Europe as well as, potentially here in the US more, the temptation may be that, technology will solve that. But without the right governance, without the right sort of processes up front, you may not be able to do so in an effective and robust manner. And I think what's important to also keep in mind is we talk about governance of an ESG program. To me, what I see also as an interesting trend is that more and more that also gets rolled into how companies think about overall risk management in the life sciences space. ESG in itself is an area of risk, but as a best practice, a lot of companies are now trying to find ways to identify ESG risks in each of their main risk domains. So think about kind of what are some maybe the strategic risks that emanate from lack of responsible governance, or how does the lack of an ESG program impact our ability to raise capital, and thus it represents a financial risk as well. So there's a lot of things that kind of, if you look at some of the key risk domains that are here on this slide, that are permeated by ESG risks as well. And the question is at any given point ESG risk material? I think currently it maybe not, right? But I think there's more and more thought being given to the fact that as we think about each of those main risk domains, we need to be evaluating what kind of ESG risks we're facing, and also what kind of governance of those risks we need in order to mitigate them. And alternatively, as we strengthen our responsible governance programs and as we strengthen our ESG programs, that will lead to an overall strengthening of our risk management. And because the more governance structures we establish as we focus on reporting, as we focus on collecting the right information for reporting, that will also help us to really mitigate other risks, particularly from a compliance and regulatory perspective, that are adjacent to ESG risks as well. So what I'm hoping that will happen, and I think as a best practice perspective is, as ESG programs mature and as the governance of those programs matures, companies will continue to see it as an important way in managing the overall strategic risks and their overall enterprise risk management programs. And in closing, I wanted to also mention that we shouldn't lose sight of the fact that an ESG program and governance of ESG obviously has inherent benefits that are very specific to life sciences companies as well. So it allows us to be better partners with our customers. I think a customer differentiation factor that is more and more important as physicians and patient organizations are becoming more discerning in who they want to partner with and work with. From the point of view of the pharmaceutical industry, there are benefits to having the right ESG programs and robust ESG programs with our employees. It helps with retention, with talent management, and it helps with our ability to really drive a successful corporate culture, and of course with investors, right? So investors are more and more looking to incorporate ESG principles in investment decisions and due diligence, and access to funding being more and more scarce, especially the scale that's required for life sciences organizations. Having the ability to tap into sustainably oriented sources of funding is going to be very beneficial to life sciences companies. And I think that as the summit continues, you see more conversations around the social aspects of ESG and issues around patient engagement and patient equity, and how what the benefits of having the right ESG practices there can be, as well as on the environmental side. But I also wanted to make sure that as we close the presentation right now, also to highlight that really what I see as key benefits to the life sciences industry of having not only effective ESG programs, but also effective governance of those programs currently, and maybe some of the key trends kind of going forward as well. What I was hoping to do is also now I can share the slides with everyone post the call, but for reference, there's also some additional sources that I found useful, particularly some of the key reports issued by some of the largest pharmaceutical companies in the world on their sustainability and ESG programs, as well as some of the key principles that we tend to apply when we do work focused on ESG here at Baker Tilly. And I'm happy to share that with everyone after the call for reference, and maybe for continuous food for thought on issues around governance in particular. But I also wanted to make sure we have a little bit of time for questions from the room, either through the chat or obviously directly on the presentation, or maybe some of the my experience in working in issues around governance in life sciences.
I have a question. Can you hear me okay?
Yep.
When thinking about ESG practices in life sciences, what do you see as the opportunities in terms of ESG helping to drive new innovation? And I've seen some work on circularity in life sciences and things like that. How is it being used? We do see that C-suite level leaders are now seeing it less just as alleviating risk, and more in that beta side of things, and more into the alpha side of this can actually drive some new innovations and profitability moving forward.
Yeah, absolutely, and that's I do see more and more focus on that, and we didn't have the chance to talk about that sort of more positive upside of ESG in this presentation, but I mean, I think if we're talking about some of the key issues like around engaging patient, for example, engaging patient populations that might have been underserved in the past, and maybe kind of driving a different product portfolio development strategy or even distribution strategy to address those it can certainly have, and I think it's certainly seen as a way to drive further commercial and kind of benefit and upside. And that's just one example, right? But I think it is more and more seen as an opportunity to drive revenue generation and to drive upside. I think particularly in with regards to some of these sort of untapped patient populations and anything in relation to kind of the social side of ESG here, I think would be quite critical for that.
Thank you for that. Appreciate it.
And one thing to add also to add to that, so it's also, I mean, to take a step further in that, particularly in the rare disease space, where patient identification actually can be also a challenge, right? Broadening kind of the scope of the types of patients that you are able to access is critical. So when you have products that are very niche or that are only targeting very specific patient groups, then broadening the scope of your patient engagement strategy is critical. So what I said before, I think is applicable across the industry, but I think is especially applicable in some ways to rare disease companies, and those, let's face it, are the ones that are getting a lot of kind of commercial attention nowadays. Sorry, was another question?
Probably have time for one more if anybody else does it.
So I also want to thank you for an incredible presentation. You've done a lot in this space. So since there are students online watching this and students in this room, since you've done such a great job on summarizing a very, very large subject matter in a short period of time, what would you suggest for those who are interested in this space? What should they be doing while they're in school and in their internships if they want to go into this space for their careers?
I think I think there's different entry points into this space from a career perspective. And I mean, I mentioned that as where ESG resides in life sciences is still kind of yet to be determined from a functional or strategic point of view in some ways. But I think always thinking about applying that lens, you know, in your work, in your applications for internships or full-time employment is critical, because it's going to be, you know, you will need to apply an ESG lens to a lot of the discussions you have in a commercial setting, in a medical setting, as well, for roles that are related to market access, right, and reimbursement as well. That's a whole other area of where I think we're seeing the need for having that lens being applied. So, you know, this concrete answer, I'd say, but like, yeah, think about it. It's important just to have that lens in mind when you have these conversations with prospective employers, and to know that it really applies to every function of a life sciences organization. So it doesn't, maybe in different ways, right? But it applies to every function, and so I think it's important to be for everyone to keep that in mind. I'll also add, I mean, some of the resources that I have in the back of the presentation, I think could be maybe interesting to go into. And then specifically from an advisory perspective, obviously, if you're looking at consulting opportunities related to life sciences and more from an advisory perspective, I think I'm happy to talk to students in more detail about that and how you can develop a career focused on ESG, or sort of having an ESG perspective and a governance perspective in interacting with life sciences here at Baker Tilly, or you know, at other organizations as well, where I know that work is also front of mind. So happy to be a resource for that as well.
Awesome. Thank you so much.
Great. Well, thank you, Mario. We appreciate you being here today, and we are going to take a couple-minute break and go on to our first in-person session.
Great. Thank you. It's a pleasure to be with you, and have a good rest of the summit, and have a good afternoon.
Yes, don't mind. Glad you told me. Go. Go.
I'll wait till that switches over. First Ackerman Center has been involved. They do it. You all do this every year, right? The ENI.
Although it hasn't been, this is the first time in like 3 years because of COVID. Been a few years without.
Bringing it back. I like it.
Bring it back.
All right, it is 1:45, so let's stay on schedule, I guess. All right. Hello, everybody. My name is Jeff Middleset. I am the Executive Director of the Ackerman Center for Excellence in Sustainability and Professor of the Practice here at Kenan-Flagler Business School. We're really excited to be helping with this, the Entrepreneurship and Innovation Exchange, and really excited to work with all of the students, Center for Business of Health, and everyone else who's been involved in this. And especially excited and thankful to our panelists that we have with us here today. This is the environmental panel. The one thing that I want to make sure that we say as well is that the environment is connected to the social and the human health aspects as well. And so we'll be looking at, just through 4 examples within a huge community of stakeholders who are impacted and who are also doing positive work to try to address the issues that we're going to talk about today, and many more. We're going to be looking at how healthcare can impact the environment, and how the environment can impact human health, and then how all of that can come back around and impact healthcare and healthcare services. So it'll be really exciting to be able to go through all of that. So we'll get into, we'll talk about environmental impacts, climate change, we'll talk about waste, and everything involved in those. So something to kind of keep in mind while we're discussing what we discuss here, because we only have 45 minutes, is that that the impacts go well beyond the immediate impacts that we'll probably talk about most today. Although we might not, we'll see where our conversation goes, but always keep in mind the impacts that are up and downstream in the life cycles of the activities and the processes and the products that we're talking about. So for example, if we're thinking about waste, which we're going to talk about, where does that waste go? What happens to it? When if it's medical waste that's incinerated, or if it goes into a landfill, who are the communities who live around those places where that happens? And how might they be disproportionately impacted in terms of their health and health impacts on them and those kinds of things? And then also when we're thinking about this, what are the opportunities? Because anytime there's a challenge, there's always an opportunity for us to, in this case, we're in a business school, use business to try to address those, but also to work together with stakeholders throughout to address them. So all of these folks are doing that. So that's the amazing thing about this panel. So I want to do a quick introduction of who everybody is, but then have you all introduce what you do and who you are and what you do in your different organizations. So we have Dr. Stephen Eckel, who's the Associate Dean of Global Engagement for UNC's Ackerman School of Pharmacy, and an Associate Professor in the Division of Practice Advancement and Clinical Education. Dr. Lindsay Gauker, who is the Assistant Professor of Anesthesiology for UNC School of Medicine, and is a Medical Director of Anesthesia Services at Chatham Hospital. Kirsten Miner is a Health Manager with Clean Air North Carolina. Great organization, check it out. I used to place interns with you all, and hopefully we'll continue to do so in the near future. Kirsten concentrates on community-focused collaboration and provides informed health education that addresses things like social determinants of health, and with the goal of reducing health disparities in communities most impacted by systemic and environmental racism. Drew Hall, who's a sales representative with Stryker Sustainability Solutions. And Stryker Sustainability Solutions is a service arm of Stryker that provides custom solutions to optimize medical reprocessing and remanufacturing, which is good for the environment and the hospital's bottom line. So appreciate all of you being here. Now, if we could take a minute or so for each of you to describe what it is you do, and both in your jobs and especially in terms of the intersection of healthcare and the environment. We'll just start at the end and work our way down. Does that sound good?
Great.
Fantastic.
As I mentioned, I am an anesthesiologist at UNC. And so I work in the operating rooms every day, and that is definitely a source of a lot of good in terms of providing healthcare, but also a source of a lot of waste, both materially, but also one of the main agents that I personally use every single day to put patients to sleep for surgery are called volatile agents or anesthetic gases, and their properties render them a greenhouse gas. I have very significant greenhouse gas warming potential on the order of 8 to 16 times that of just CO2. The way that we deliver that anesthesia gas has been inefficient for many, many years. And that has been tied to some previous concerns for the risks of delivering it too concentrated. Those risks have sort of been completely quelled and confirmed to not be an issue. And so my job, or my sort of interest at UNC, has been promoting a big behavior change in how we deliver those anesthesia gases so as to minimize the waste and therefore the greenhouse warming potential that they contribute. And just for a little bit of understanding of the sort of scale, the whole healthcare system as a whole in the US, in terms of anesthesia gases, the greenhouse warming potential that we contribute is greater than that of the entire United Kingdom. So United States healthcare is a big, big contributor. And so we all have a part to hopefully make a better impact and change.
Wow,
so that's what I'm trying to do. We've had some good success, which I can talk about if there's interest later.
Thank you for that.
Yeah.
That's an enormous number. I didn't know that.
Yes, substantial.
All right.
Well, if you sort of take her example in gases, you would apply the same to me with pharmaceuticals. Longtime pharmacy administrator at UNC Medical Center, and over the time of my career, one of the things you spend a lot of time thinking about is actually how do you dispose of unused medications. And I remember early on in my career, we would store narcotics waiting for the DEA to come in to get rid of them, and they would watch us flush them all down the toilet. And that was the original way to get rid of narcotics. Clearly, we don't do that anymore because the pharmaceuticals being detected in the wastewater has been well documented. And so now we find different ways of getting rid of them, like incineration. But that's sort of the macro aspect of what do you do with unused medications, as well as those that have expired. The other major aspect that happens is medical waste. And for example, some of the drugs that we deal with are known to be hazardous. And prime example is chemotherapy. So hazardous drugs are those that know that if they come into contact with somebody, that's not very good. And there's negative outcomes associated with it. And so every individual that's involved with both preparing chemotherapy as well as administering chemotherapy, there's a lot of waste that is generated from the IV lines, the gloves, to the gowns that people wear. And all of those have to be placed in medical waste, but not that goes to the landfill, but goes to getting incinerated. And so that then becomes a large issue, such that we will come and get evaluated from different agencies and would be fined if we are not following the right, proper regulations, procedures. The third part I'll sort of bring out that might be some interesting questions is then as we be thinking of sort of the environment, the other aspect is protection of healthcare workers. And so I mentioned that example of chemotherapy. The risk of them getting exposed to chemotherapy just through the preparation of that drug and through the administration of drug is there. And so then we also have to ensure not only are we protecting the environment, but we're also doing our healthcare workers through those same processes there.
Thank you so much. Kirsten.
I'm gonna try to connect the dots. So again, my name is Kirsten Miner. I work for Clean Air NC. We are a statewide nonprofit with 2 offices, one in Charlotte, one in RTP. We have 5 programs. So in addition to the health program, we have our community science program, our environmental justice program, our advocacy program, which is our policy wing, and then education. So when you hear about medical waste, or even in regards to incineration, the role of healthcare workers, not only educating them, but making sure that they're aware of ways in which they can protect themselves, as well as obviously protect the general public. All of 5 programs I just mentioned, they all feed into each other. So as the health program manager, I have a 2-pronged approach. First thing is I work with healthcare professionals, and when I say healthcare professionals, it's very inclusive. So that is your clinicians, your nurses, your social workers, because social workers, social determinants of health, where people live, work, and play. Public health professionals, which is what my background is, we're all play a role in, of course, providing services, whether it's in a clinical setting or in a community-based setting. Essentially, but when it comes to actual curriculum, medical schools historically have not been inclusive to the length that it should be, arguably when it comes to the role of environmental and climate factors contributing or exacerbating health disparities at a public health macro level. So to address that gap in medical school curriculum, we originally would actually go into the medical schools and do that environmental education piece, climate change educational piece. So as obviously during residencies, those students matriculate and go into the spaces that they will work in, they have climate and environmental factors in the back of their mind, but also by them having that education, they're better able to communicate with their patients. So that's one side. Healthcare practitioners specifically, every couple of years, they actually do a survey of what are the most trusted professions, and consistently doctors and nurses, but especially nurses, are viewed as number 1. people trust their nurses and doctors. I know there's been a lot of challenges around COVID-19 and, you know, misinformation and in general. However, public health, when it comes to messaging, we are fully aware of the general public does trust their healthcare providers. So if we're able to, of course, inform providers around the climate and environmental aspects, they can actually serve as advocates to influence policy. Because at the end of the day, anytime that we're trying to advance changes, it really does require policy changes. So it's a lot there, but the other side is community outreach. So the communities that are most impacted disproportionately by air pollution, other sources of pollution. We actually go to where they are and learn of what are the health topics they're most interested in learning about, whether it's the role of air pollution in exacerbating diabetes or asthma or cardiovascular health outcomes. Those same healthcare practitioners I just mentioned, if we have a cardiologist or, you know, anesthesiologist, whoever it may be who specializes in a particular area of expertise that the community members are interested in learning in, we will assemble them and actually put together an actual education series. So it's a lot, but we'll talk more later.
Awesome, that's great.
Hey, I'm Drew Hall. I'm a sales representative with Stryker Sustainability, which is the sole reprocessing division of Stryker, which is a big company. So that's what our division is, and it's totally 100% reprocessing, and we don't focus on anything else. So really, two main goals of our division is environmental sustainability and then financial sustainability for hospitals. So we looked at, when we first started this division in around 2015, they looked at hospital waste and realized that hospital waste is the second greatest contributor to landfills behind the fast food industry, and looked at what we could do as a big company to provide for some of that and to try to adjust some of that. So what we looked at doing is just reprocessing products and thought, if we can reduce the amount of waste that ends up in the landfill and also reduce the cost per case for hospitals and the cost per device for hospitals, then we can knock out two birds with one stone, and we can reinvest some of those savings, or the hospital can reinvest some of those savings back into better patient outcomes overall. Yeah, really excited about this. I mean, this is right up our alley, so thank you for having me. A little intimidated by the titles of these three, just being a sales rep, but excited to share about our company and our division.
Fantastic. Thank you all for setting the stage so well. So each of you talked about some of the issues that you deal with and a little bit about what it looks like, for example, when there's waste or the amount of greenhouse gas emissions from certain processes. But can you dive into more detail about some of the operational issues that you're seeing, but then also what are some of the solutions that you're more detail about the solutions that you're either advocating for or trying to create through your work?
I can talk a little bit. For my particular project with sort of trying to improve our efficiency with the delivery of those anesthesia gases, a lot of the initial discussion and looking at the problem as to why are we still doing it this way, and effectively, to kind of put it in simple terms, we are diluting down our delivery of anesthesia gases more than we need to. So when we dilute it, we are administering more. There is excess waste related to that dilution. And that stemmed back from some historical data that was pretty basic and actually not even done in humans, but we are all sort of tied here in the US with the FDA, and there's a lot of regulatory agencies that weigh in on certain things, and that is always balanced against liability and concerns for safety and risk, but also there's, we all know that there's legal sides of things that get that weigh in on some of these decisions. And so once the FDA makes a recommendation, that sort of becomes that just becomes what is done from going forward. And it took a long time for folks to really take a look at some of that data and say, is this really necessary? Look at all these other countries that aren't doing it this way, countries that don't have the luxury of the finances and resources of the US and had to be more conservative and not have so much waste. And they were doing it safely and improving that. And so what we discovered is that what we did some surveys of our team and trying to understand like why aren't we updating our practice, and that's because there's just there wasn't a lot out there until more recently, probably in the last 5 years. There's been a big push from like within our own national organization to take a look at our own practice and how we're contributing, and so not really understanding, not being educated, and then just kind of hanging on to some old behaviors. Like it's literally just practice to push 2 buttons on our anesthesia machine, and that's the way that those gases get diluted. And so we took, it was a project I did with a bunch of residents, and we did a whole rollout of an education and sort of reassurance that, you know, this is safe, here's all the data, and here's, you know, what our national organizations are saying. And we did some monitoring of how people were delivering it, and we made some really good strides. We definitely had some pushback of folks in our department. Some folks are a little more old school. Some people just don't like change, which is just very frustrating to hear. And some people honestly felt like, what does it matter? It's just a drop in the bucket. And when you look at the context of like the system that we work in, so much is out of our control. I don't control the amount of plastic that everything comes wrapped in. I don't control the Joint Commission and the things that they tell us that we have to do for infection prevention. And there's lots of regulations. And so people feel a little bit like they don't have real command of making real change. But we have really emphasized on this is actually one thing we can control, and we feel like it's our obligation to not only to protect the health of the patients we're taking care of, but just some of the issues that you mentioned, that all of the waste that we're generating is creating an unhealthy environment to live in, therefore resulting in patients coming into the hospital related to their poor health, and it's a bit circular. And so trying to push those sort of that messaging and doing more of leading with a carrot as opposed to beating with a stick kind of has worked well. And we're just kind of continuing that messaging and checking in every month and monitoring. So far, we've had really good success, and I feel good about it. It's taken a lot. It's incredible the amount of work it takes to make behavior change. That's a little bit of what I've done.
Yeah, I can follow up to that, especially when it comes to gases.
Yeah.
So one of the ways that medical device reprocessing and remanufacturing had been done historically, whether through a company or in-house of the hospital, is using ethylene oxide, which is not great for the environment. So our division decided 2 years ago to make the switch to hydrogen peroxide, which is more expensive, but that's something that we obviously believe in with our company, and so made that change. Some other processes that we started doing, and we have a goal of being a zero landfill reprocessing company by 2025. So everything that we're doing is on the way to get there, such as we have changed the way that we package our devices right now, and we've started using soy ink. We've started using material that can be recycled a little bit easier and broken down a little bit easier, even though sometimes that soy ink is apparently slick, and we get some complaints from end users on the boxes sliding around a little bit more than normal, but we stand by it. And then other than that, we also partner with UPS, and we know we sell over 1,000 different products that's used in virtually every hospital. So we're sitting on a lot of packages every single day. And so obviously that's producing a lot of carbon emissions. So what can we do as a company to combat that? So we've partnered with UPS and their carbon emission offset program. So all the spend that we have with them, a certain portion of that goes to buy carbon offset devices and things like that to try to help with that. So there's lots of things that we can do, and we're always looking for new opportunities to try to reduce our footprint as well.
Thinking about processes and again, monitoring. So Clean Air NC, our roots began in Charlotte. So a lot of our work historically, it's been Mecklenburg focused. Mecklenburg County obviously is, in regards to Charlotte, it's very unique in that they actually have their own county level air division quality, whereas Forsyth also has a county level air division quality, but the remaining 98 of 100 counties in North Carolina, when it comes to enforcement and environmental, we have the Department of Environmental Quality. What we have been successful doing in Mecklenburg, but this is something that we like to replicate, but tailor specifically to the different counties, because Mecklenburg, again, is an outlier. North Carolina is very diverse in terms of the different environmental challenges, et cetera. But with that being said, our community science program, what makes us unique is that we actually provide community members with, we use these air monitors called purple air monitors. Purple air monitors actually capture and is able to report back information regarding to particulate matter or PM10, PM2.5, PM2.5. There's anything I say from presentation is PM2.5, the reason why we focus so much on that particular air pollutant is because it literally can contribute and exacerbate any health outcome that you can think of. Because it's very, very small, 2.5 is just the size of the actual pollutant, and it's a combination of different sources, whether it's dust, soot, etc. It's a chemical cocktail. But when we breathe, because we all breathe air, that's not debatable. When we breathe, we actually, because you can't see it, it's invisible. But obviously when we inhale it, it goes into our body stream. And because it's so small, it can actually not only get into our lungs, but it can actually go into the bloodstream. And when it goes into the bloodstream, it can lead to inflammation. Inflammation literally can be the starting point for a variety of diseases, whether it's diabetes, asthma, cancer, etc. So when people obviously, how can we convince people about pollution if they can't see it? Well, the only way you can do that is through monitoring. So these purple air beams, there's two different forms, but the ones that we use are stationary. These are low cost sensors. On average, I think when it first started around 2016, and maybe the price for one purple air was maybe around 150. It's inflation, so prices are slowly but surely going up. Because more people actually are interested in low cost sensors, but nonetheless, there's a community in Charlotte called the Historic West End, which is a historically redlined community. I'm not sure if people know redlining, but redlining was a policy decision. So policy, these are man-made decisions, meaning that there can be man-made solutions, but back in the 1930s and throughout really where people live today is still reflective of these policy decision-making processes. But more or less, they use a color-coded map where literally if you were marked in the green, then that was community that was considered the best place to live. And there was investments in those respective communities. And obviously redline, hence the word redline communities. These are communities that were considered actually hazardous and were unsafe places to live. So there was divestment from those respective communities. So when we think about waste, whether it's, I'm going to use the example of a landfill, since we keep speaking of landfills, all of North Carolina's waste actually ends up in Sampson County. Sampson County is southeastern North Carolina. They have the largest landfill that releases a variety of gases, but methane gases in particular as it regards of greenhouse gas emissions. So yeah, everything that we throw away ends up in Sampson County. But nonetheless, the reason I want to mention that is we're able to, I'm bouncing around, so I apologize. But these purple air sensors in the historic West End in this red line community, there was 3 community leaders that represent different parts of the historic West End. We were able to equip them with purple air sensors, train them of, okay, this is how you collect the data. What does this mean? And essentially over a period of time, they were actually able to put together a report with technical support from our community science manager at the time. And from that report, they actually decided to present it at the Mecklenburg County Commission. At the Mecklenburg County Commission, they shared in regards of the concerns, the baseline community, or the comparison community rather, was Myers Park is a more well-off, well-to-do area in Charlotte. So they were actually able to show that there was higher peaks of particulate matter exposure in the historic West End compared to Myers Park. And of course, the health piece of how exposure to air pollution can contribute to health disparities. So all of that was condensed into this report. And the community leader at the time, Ron Ross, who still works with us, he's an air keeper. He just happened to ask at this county commission presentation, hey, can we get a federal air monitor? So regulatory agency, the EPA, Environmental Protection Agency, they have federal air monitors, which are very expensive air monitors that are not affordable and you can't just purchase. But at the time, there was no federal air monitor in the historic West End. So it just so happened the stars aligned that with that report, and there was actually a federal air monitor available, they were actually able to get a federal air monitor established in the historic West End. And why is that important for everyone who has a smartphone? If you get on your weather app of your choice and you see a reading that says that today is a great day to go outside and exercise, or pollen levels are high, and things of that nature, it's the air quality index, or AQI. It's a color coded chart. So if it's green, you're good to go. If it gets into yellow, if you're a person with an underlying health condition such as asthma, you want to take precautions of going out and about. And anything in the red and above is really, it's not safe for anyone. But now community members to that federal air monitor, they can literally look on their app and make an informed health decision. And that federal air monitor can also support policy changes. So that's very, very important. So that's a plus there.
Thank you so much for sharing that. Good, thanks.
Yeah, so just a brief, the biggest thing that we consider is education. Educating mostly healthcare workers on the different risks of the medications, as well as the different disposals of the medications. And because there's significant healthcare turnover, we're always striving to provide different ways to give that education to individuals so that when they're at a point of disposal or sort of they're compounding a medication, that they know exactly what the risks are, both to them as well as to disposal of the drug, so that they would be able to prepare themselves the right way and dispose of it in the right sector.
All right, so we've gotten a lot of incredible information. So we have some challenges, definitely unveiled some of those. And Kirsten, you did a great job of starting to illustrate partnership, collaboration across different stakeholders and how important that is. We're not there yet, but we need to continue down that road. With each of all the work that you all do, what are some opportunities for partnership and collaboration across stakeholders, and who are those stakeholders? You know, whether it has to do with how long it takes to change policy, or even technical advancements that, like Lindsay, like you had shared with me, a company that's trying to capture that gas and sterilize it and be able to reuse it. What are some of the opportunities for us to work with different stakeholders or different groups, whether it's industry, policy, government, any of the schools across this campus, to try to address these?
I mean, the operating room is a huge beast and I think there's so many opportunities. So yes, the one I specifically shared with Jeff via email, there is a company out there that is actually looking at, so those anesthesia gases that we use to put people to sleep, they go in the body, they go to the brain, they quiet your brain, you're off to sleep. And when we're done, we kind of leach them all back out of your body, down concentration gradients. The beauty of that is that they are not actually changed in any way, shape, or form when they're in the body. So there's no metabolism, there's no structural changes. So when they come out, you can reuse them again. And we actually do, while a patient is under surgery, we have, that's kind of the change that I made, the practice change. I didn't go into it too much, but it is very much like recycling the patient's own gases and keeping them asleep with what we initially start with and just running it around a big circle. But that could also be translated into actually using it on another patient, because the gases themselves are still effective at what they do, even after they're sort of removed from the body. And there are companies out there that have taken on that project and have created a product where there's I don't know the technology and how it works exactly, but it's like a canister that sort of is in line with the breathing machine and it captures all that gas. There's anesthesia gases, and then it does some sort of cleaning process and then repackages them and makes them available for another patient. And so instead of them just being exerted into the atmosphere, which is what happens right now in 99.99% of operating rooms, And then they just go to live in the atmosphere and are greenhouse gases and contribute to global warming. Instead, they would be captured in a canister and then reused on a patient, on another patient. And so, I mean, certainly that's an amazing, I think, example. But there's a reason we don't all do that right now. And I think that there's challenges related to the cost of sort of doing that. Certainly, I'm sure you've experienced, there are some challenges of getting people, healthcare organizations to pay money up front for savings that that may not be recognized for many years, months, weeks, whatever it may be down the road. And so that's one big hurdle I think we all sort of struggle with trying to overcome when we're not the ones in charge of the budget. And sort of you can see the promise and you can see the potential, but getting somebody in another department who has lots of different people trying to sort of advocate for their funding, oftentimes we lose on that front. But my hope is that that continues to grow and become a much bigger sort of part of what healthcare systems are recognizing as ways to really be more financially sustainable. I think another big avenue within healthcare, especially in the operating room, is actually HVAC systems, which is another area where I'm trying to get some traction. We're building a brand new operating room. It's going to be amazing. It's a huge tower, all new operating rooms. We've been in the same one since the 60s, so it's time for an upgrade. But the HVAC systems are actually a really big consumer of energy and money for the energy that it takes to run the circulation of the air in the room. And there are standards that are set by regulatory agencies of how frequently the air has to be cleaned in an operating room. So there's two standards, one while the operating room is not being used. So there's like a baseline circulation and cleaning. And then there's a separate standard that has to take place while a patient is actually in the operating room having surgery, because we want the air to be clean and sterile so as not to introduce infection into an open body cavity. And so right now at UNC and the main operating rooms that we have 30 plus operating rooms, and that HVAC system cycles the air 36 times an hour, and it's like that 24 hours a day, 7 days a week. Our 30 operating rooms do not run 24 hours a day, 7 days a week. And so there is a big push to have HVAC systems and they exist, that actually can sense when a patient's coming in the room. It triggers the cycling to change in relation to that, the lights, et cetera, all of the things that sort of are required when a patient's in the room, but are not required when not in use. And so trying to get your HVAC system and the folks who implement that to recognize that that's a worthwhile endeavor. It's out there, and hopefully we're working towards that with the new tower, but it's like another example, I think, of where there's great cost savings for the healthcare system, but I think getting people to appreciate that and then get the right people in the room to talk about how to actually do it is a whole nother step that I found challenging.
So I'd like to, for me on the partnership side, I was really intrigued by Stryker's, at least your division's goal of reducing waste.
Yeah.
I mean, so on the pharmacy piece, if you've ever noticed about how medications are packaged, a lot of it obviously is FDA regulated, but they come in a box. They've got package inserts on every medication. They're wrapped, they've got cotton in there many times. And when a pharmacist is filling a medication, they just automatically throw all those things away. And so you're bringing a whole lot of trash that comes out of the packaging that never gets looked at, never gets evaluated. But by most of the time FDA regulation, they have to have a patient package insert and all these things in there. And I'm not aware on the pharmaceutical side of any sort of company coming forward with saying our goal is to reduce waste, like what I just heard from Stryker's perspective. And so to get at your question, I think more public-private partnerships around with this electronic world out there, doing a better job to reconsider packaging from the perspective of reducing waste. I think many companies, they've got their manufacturing line set up. It's already been approved by the FDA. It's just much easier to keep it as is. There's an aspect of branding to what they do, so you can recognize it with the eye. But I think as healthcare institutions recognize the amount of expense and the environmental issues associated with that, some public-private partnership around working with companies that are willing to put the expense in to reduce the environmental footprint later on. I think a lot of healthcare institutions would be okay with some level of partnership so that could move the environment or the sort of the packaging and the waste in that setting, because it's unbelievable how much waste we generate. I just speak here now on the pharmacy side, just from packaging, and it's stuff that never gets looked at.
We have stuff that is plastic, wrapped in plastic, wrapped in plastic. It's incredibly, it's insane. And it's definitely a balance of like infection prevention, which is there's so much focus on that. And it's incredibly important. But it feels we've gone very, very far one way with that and not sort of balancing just like the elements of good, reasonable practice at sort of maintaining good infection prevention standards without everything being triple wrapped in plastic. It truly is. Like we have an example, same thing as we have a central, what's called the central line. It's a big IV that we put in patients when they're having a big surgery, but it comes in this big pack. And then within that pack, there's probably 15 things that we never use, but it's a standard pack that comes. And there's no way to be able to change it to your institutional's preferences and practices. So there's just so much waste every time, and it is really hard. I feel powerless sometimes to do those big changes because I don't know who to go to start. So it's lovely to hear all of this.
Yeah. Sorry.
Collaborative partnerships. So aside from obviously meeting community members where they live, work, play, and learning what they're most interested in, and meeting them where they're at, providing those resources. This historical funding coming down from the federal government, you have, of course, the Inflation Reduction Act, and then you have the Black Principle. So this is the most historical funding ever focusing specifically on climate justice issues. I spoke about the EPA earlier because there's a lot of collaborative problem solving grants available at this time, environmental justice collaborative problem solving grants, which that grant specifically encourages where oftentimes we work in our own silos, whether it's the private sector is over here, healthcare sector is over here, nonprofit, education, we're all in our own respective worlds, is environmental justice problem collaborative solution grant literally is forcing, more or less, it's not forcing, it strongly encourages you have to work with a minimum of 3, if not more, partners across diverse sectors to come to a common shared solution. So I think that I'm not sure in regards of, I know that a grant that we were just awarded, I mentioned Sampson County earlier, that wasn't through the Environmental Justice Collaborative Problem Solving Grant, but nonetheless, we are working with research institutions, so RTI International specifically, who they do a variety of different services, but they have a very massive reach. In regards of working with universities, she mentioned that obviously in prior work, we do look to collaborate with universities because obviously universities you guys are research leaders, and not only just being research leaders, but obviously during your studies, as you matriculate, you guys are the future business leaders, the future doctors, the future, working in all the different sectors, regardless of what you're studying. So it's very important for us to work with higher education institutions. We want to expand more into partnering with the private sector or business sector because there's a piece there, obviously, as well. So I think that we really need to start tearing down these silos because it seems like even just this panel itself, we all represent different spaces, but we all have a shared goal of trying to minimize, reduce waste, reduce greenhouse gas emissions. So it seems so simple, but if we literally are all able to gather here in this room or the different spaces that we are and just really come up with, if there's funding coming down and we work together on a grant, that would give us the funding necessary to address all the concerns that I feel like we're speaking to today.
Yeah, that's awesome. And to highlight just the sheer amount of hospital waste that we're talking about, I wanted to share this data with you. So 33 pounds of hospital waste is generated per bed per day. If you think about that, like that's enormous. Take a UNC Maine hospital, 811 beds, a little napkin math tells me that that would be 27,000 pounds of waste generated every day and 9.7 million pounds of waste generated every year. So specific to our division, our company, I got here a year ago. I was in Alabama for 2 years prior, where if I mentioned environment, they thought I was talking about whether Alabama or Auburn has the best game day environment. That's what they thought I was talking about. But come here and, walking into UNC for the first time, previously we had saved them $1.5 million the year before. They saved $1.8 million last year, which is great, and they can do a lot with that. But we're missing out somewhere. There's other products that are being used that maybe they can't purchase, reprocess because of a contract. But talking about using stakeholders in a system that believes in the program, it was really easy to go to UNC's system leadership and have conversations around, for example, pulse oximeter sensors that are used on virtually every patient. And there's hundreds of thousands of these being used across the system that were being thrown in the trash, just generating hundreds of thousands of pounds of waste. So UNC can't use those from us because of a contract, but what we can do is we can collect them. And on top of diverting that waste to another hospital that can use them, we're also paying UNC 25 cents for every one that we collect. So UNC is getting free money, they're getting waste diversion there, and they're kind of doing the best of both worlds, where they're using reprocess to save money and they're letting us collect everything that they can't use reprocess. So yeah, UNC has been by far the greatest health system I've ever worked with. And on Monday, I'm going to walk over to Duke and tell them the same thing. But yeah, I mean, UNC as a system is super bought in, and it's been exciting to see.
We have time for a question or two. Any questions? Yeah.
I'm kind of entering in healthcare sector for a while now, and seeing like how the drug industry really works and everything else. Like, is it even possible to go towards really net zero of the emission and of the impact, or is that just like a really far point in the future? I guess it's a question for everyone. So yeah, from your own perspective.
Yeah, I'll answer that just quickly on our stuff. So zero emissions, probably not, because we still have to ship our products out. But as far as like zero landfill, yes, there's things that we can do with our packaging to reduce the amount that ends up there, or maybe reduce it down to zero, to nothing. These products, just like any product, eventually will come up on end of life, whether they get one reprocessing turn or up to 20 on some of the non-invasive products can get 20 turns, but eventually they're going to hit end of life. So instead of throwing those away ourselves and those ending up in the landfill, we partner with, I believe the company, it's a third-party recycler called Right Cycle. And they take all the metal, they take any other precious material out of there, and they recycle that for us. So yeah, there's things that we can do certainly on the landfill base, but as far as the emissions, until we get electric Amazon Prime vehicles rolling around in UPS trucks.
I was gonna say, Item was just here, 2 days ago? Well, down the street in Durham, but in regards to the transportation sectors, that's actually the #1 source of greenhouse gas emissions in the state of North Carolina, followed by the electricity sector. So of course, electricity that we use within our homes. #3 would be industry, and industry is comprises, of course, if you think about your gosh, I go blank sometimes, I apologize. But industry sector, but also is inclusive of concentrated animal feeder operations, or CAFOs, which is a huge issue here in North Carolina, specifically Eastern North Carolina. But going back to the historical funding and Executive Order 271, which was specifically around electrification of medium heavy duty trucks, which is NC Clean Transportation Plan, which is still in a developing process. We're going to see more electrification of medium heavy duty trucks. So your delivery, whether it's Amazon or UPS or FedEx, it's a slow but sure process. But I do have hope because that specific executive order is trying to reduce greenhouse gas emissions from, again, those medium heavy duty trucks. Individual cars, I think that now, obviously, you know, it's a slow, gradual process, but more and more larger businesses and companies. I think that California just recently, they banned the sale of gas-filled vehicles. It will be in 2035, I believe, or maybe 2030. So anytime that there's a change, whether it's happening in California or New York or Massachusetts, those are typically the states that kind of set the model for other states to join on board. But I think that, again, in regards of when we say global warming, climate change, in different language that we all different use, is that it's becoming harder to debate whether it's really happening or not, because we are experiencing more severe weather. Even, I mean, I'm not that old, but I definitely remember, I was like growing up, all 4 seasons were solid 4 seasons. Just this past month, we had a heat wave and a cold front. Now it's, you know, it's getting hot again, cold, but even in regards of flooding, hurricane seasons, super hot, that's actually heat weather related illness is the #1 cause of weather related death specifically. Those are issues that we're living in. So when people are like, why is it so hot? Or, you know, why is, you know, certain places getting, you know, weather conditions that normally it wouldn't be exposed to. I think at a global level, more people are buying into this is a real issue. And at the end of the day, we only have one planet, which is planet Earth. Or one planet that we can live on. We have 9 planets, if they still want to consider Pluto. But Pluto apparently is no longer a planet. But planet Earth, we obviously need to work together if we want to be here, not only for, of course, our lifetime, but future generations as well. So the optimistic side of me, I have my days, but I do believe that we're doing our due diligence to reduce greenhouse gas emissions across the board. It's just, it takes time. And of course, they say we don't have a lot of time, but hearing that there are, obviously, in regards, I'm learning a lot in regards of Stryker, we all have the ability to make those small changes. It may seem like, oh, you know, what point at this, if there's so many things, if we think that your one action, whether it's, you know, recycling means nothing, it does mean something in the grand scheme of things. So just look at it from that lens, as opposed to it's just too much, and then we don't take actions.
Yeah, so I'm Brett. I'm one of the students that helped organize this. Thank you, panelists, for being here. Really great session. Thank you, everyone else, for being here as well. I do have one follow-up question, and we're a little bit over our time, but I talked to Suzanne, and we're just going to extend this for like another couple minutes, and then we'll kind of push everything else and condense some of the breaks that we had, as long as that's okay with everyone. Did anyone else have a question? They did have one, but
as you mentioned, in the state of North Carolina, electricity is the #1 greenhouse gas producer, kind of, or consumer, or pollution. So when we are talking about making heavy duty trucks as a battery operated, how much more pollution we are making for electricity, how that compensated, or how that calculated that it's helping us to make the environment much green, right? Because we having the battery operated truck, they're going to be taxed more on the electricity grid, right? How that's going to be, are we thinking about that? How that impact is calculated? So that's my kind of follow up on your comment.
Yeah, so that's not my area of expertise, so I don't want to miscommunicate or give wrong information. I think that's a big question as we do transition away from fossil fuels into renewable energy sources, whether it's, obviously, spoke about electrification of, you know, the transportation sector, and the stress that can put on the grid. I trust in regards of the engineers and individuals who specialize in that space. I wish I could give that answer, but I'm not quite sure. But of course, aside from electricity, or the electrification process, other renewable energy sources. So it's not just whether it's solar panels or wind harvesting, et cetera. There's other renewable energy sources that do not require us going into the engineering process, but I'm not an engineer. I have no idea what's going on. I'm being honest, but good question for an electrical engineering person.
Electric vehicles they're an enabler for us to put more renewable energy on the grid, but also to decentralize like energy sources and electricity sources. So they can be used as part of the grid, and especially when combined with storage. But if you have more questions, we can talk more.
My question that I had, I'm an MBA, by the way. I'm not like an MHA or an MD or anything like that. So my healthcare knowledge is a little bit more limited, but I think the concept of everyone doing their part is a very noble one. But I think until the business incentives somehow get aligned, or government legislation, something like that. So would love to hear your opinion on whether it's really the government, business leadership, the workforce, i.e. us, or entrepreneurs that play the biggest role in kind of facilitating and shifting that change towards the value and importance of sustainability in healthcare.
I mean, I think government plays a big role because there is so much regulation regarding healthcare, how things are packaged, what can be used, expiration dates. I mean, the amount of stuff we have to throw away because it's expired. It's plastic wrapped in plastic, but it expires. And there's like a lot of backstory as to why that is, but you have to question. I think there's some industry incentive too for making things expire, because then the hospital has to buy new to replace old. And so I think that there is incentive to keep things the way they are and generate more waste from a business side. And then from the government side, I think there's, it's thought to be protective, but I think kind of looking at the big picture of like, are we creating a more unhealthy situation by going to this really far sort of space of everything from an infection prevention and sterility and patient safety perspective? And then there's got to be a balance in there. I think it requires people other than business and legislators in the room making those decisions. I think there really needs to be people whose boots are on the ground involved. And I don't think in the past that's been well represented.
Yeah, and to sort of build on that, I think there's always an entrepreneur that's creating a new market, a new opportunity that leads to the government regulation. And while it may or may not be easy to sort of stand that up and be the first to do that, there's great examples of people trying to innovate around waste and other unused products. So what I was thinking about as you were saying it, we had talked about this, but one of the, we were actually mentioning earlier, but one of the big issues out there on waste and medications is that you get prescribed amount of drug from your doctor, yet you don't maybe use it all for a variety of different reasons, and that sits in your shelf until you finally get rid of it. There's some, I know in Tennessee, there's a great example of being able to safely redispense those to other patients if they've been held in right ways. But that's reutilizing things that, because an individual took that forward, they were able to find legislative ways around it. So, I mean, I think we just need to see more and more examples of good entrepreneurs who uses good science to drive change. Thank you.
Yeah, and I think with our division, the incentive is saving money. The incentive is saving money and saving the environment. And to highlight that, give a quick story on a specific product. One of the hospital systems about 20 miles from here, which I won't mention, they decided there's a product in the GYN space called MyoSure that we remanufacture. So they were going to save about $500,000 on that. But not all the physicians were on board with wanting to use a remanufactured product for that. They started outside of the financial aspect. started really appreciating the fact that on that specific device, the original version comes with tubing on it. We replaced that tubing with PVC-free tubing. We replaced the box with a more environmentally friendly box and packaging and all that. And so there's definitely some just awareness that needs to be spread about all the benefits from our end on all the savings that are associated with it. But more importantly, I think for end users is getting on board and getting bought in with the environmental aspect of it as well. Thank you. We are at time. We've actually run about 12 minutes over time, but it was a really good session. So thank you. And to Jeff for facilitating. We're just going to take a 5-minute break instead of a 10-minute break. Is that okay, Aaron? And then we'll start back up with the next panel.
I was going to say, we're gonna have to. I know that's old school or QR code.
Yes, it did. Yes, that's
Yeah.
you start interacting with the physician will start entering things. That's why part of the visit is the physician interacting with the system, often not even looking at you. What is he trying to do or she's trying to do is to make sure the order entry system gets it right. The order entry system is a finely, very precisely designed formulary system that essentially creates that prescription that matches your profile. That's AI, believe me. Okay. So now building upon that, we're all very excited with AI in healthcare because the adoption of computing in healthcare in a much more wider scale than it used to be. In the last 10, 15 years or so, use of essentially electronic health record system. Last 10 to 15 years or so, use of electronic health record system has gone from something like 30% in large hospitals to 90%. That's it. You can check out the charts and the graphs. So when you deploy that level of technology in healthcare to essentially do filing and capturing of records, after a few years, you begin to wonder, now that we have all of this in digital form, what can we do with this besides finding the patient quickly from the system? That's the era we are in. Believe it or not, medicine, this is the coolest part. That's why I'm so excited to be in healthcare and IT. Healthcare in the US at least has been the slowest in adopting advanced technology. We are in the days, I remind my student, because I'm old enough now, when I was in grad school, that's when the browser was invented, the internet browser. We're in the days in healthcare now with technology, the browser is beginning to be invented. Can you imagine the next 10, 15 years where we're gonna be? You think we have a lot to get excited about now? You ain't seen nothing yet. So that's what gets me up in the morning every day and say, to work, because I missed that first internet revolution. Not quite. All right, so in that context of excitement, let's put this into context. If I can get to my page. There you go. So this data is showing mortality among maternal conditions that women face among the developed countries in the world, right? The top economies. Who is the highest? Does that make sense? Depending on your perspective. Doesn't make sense, actually, really. It's sad. And if I put this statistics, that's even more scary. That last one is for African American women, mortality. So what the heck is going on? So I just finished telling you about advanced technology adoption, 90% rate of adoption of digitization in healthcare. We have all of these tools and technologies, but we have disparity. That's what this session is about, is where is this disparity? How should we understand this disparity, yet create sustainable businesses and innovation? Right? So equity and the distance between, healthcare and certain populations in our country and how do we reduce the distance is one huge area. And if nothing makes a case for equity and what the problem is, that number alone should make the case. Obviously, we're just talking about maternity health. There are other health problems, right? So equity is one issue for us to think about, and it is a serious issue, hugely problematic issue. So I ran a project at UNC called AMMI, AMMI. It stands for Analytics, Machine Learning, Maternity Health, Intervention. I'm not going to stand here and say analytics and machine learning is going to solve this problem. I didn't get into it to solve really this problem, believe me, to be honest. NIH won't like to hear that because they gave me some money to do this project. The reason behind using analytics and machine learning for me is, this is the secret of machine learning. Not only helps you potentially to predict and classify, to improve the accuracy of your prediction, also tries to explain, if you use it properly, what are the contributory factors to the risk. And you want to sort those factors, and you have hundreds of factors, you have clinical factors, socioeconomic factors, you bring them together and you apply the right method, it'll allow you to sort them out. The explanation of contribution in itself is very important because we don't understand. We can say, well, it's kind of obvious, you know, what the problem is, sure, but we need scientific evidence. Right? So we're trying to bring socioeconomic factors called social determinants of health and clinical factors and trying to decipher this puzzle in a scientific way, if possible. I don't know if we'll achieve it, but we're going to try. So besides equity, access. What do we mean by access as a barrier? We get excited about technology, but we also are creating barriers. You know, during COVID, there were families that traveled in rural areas to the closest library because they never had to experience logging in to their school. The library, the public library Wi-Fi, they could use to get access to school. That's access. If we get too excited about telehealth, online health, virtual health, think about access. And then comes safety and efficacy. In healthcare, you get an algorithm to do risk analysis at 90%, 95%, don't get excited. Not good enough in healthcare. We need 100%. Right? And last but not least, I don't know if you saw the New York Times today. There was a very interesting article on essentially arrest of people using facial recognition, which got things wrong, terribly wrong. And this individual does a case study on one single person who was arrested for stealing stuff in a state he never visited. And he actually was sent to prison. So that last area of machine learning is bias and fairness. How do we address that? Machine learning is as good as the data we provided to train. And if the data itself contains bias and we have bias, which we don't talk about too many times, we're going to end up with tools that reflect us. Why are we surprised? Maybe this is the time when we get to see ourselves in mirror, clear mirror. Say, whoa! I don't want to get too philosophical here. So with that, I'm going to introduce my panel. I'm so proud to have a very illustrious, very, very important panel here. So let's start from the end, and please introduce yourself, your affiliation, and give us a short position statement on what area you want to focus on and you are excited about.
You bet. So I'm Dr. Chris D'Arienzo. I'm a neonatologist clinically. And up until 2 months ago, I was a health system chief medical officer over at WakeMed in Raleigh. WakeMed is a 3-hospital system, community health system that has equity built into its DNA, given why it was founded in Wake County. But 2 months ago, I was fortunate to join the American Hospital Association as its chief physician executive. So my clinical career is on pause for the moment because I'm on a plane every week instead, visiting with our members who represent a wide variety of hospitals and health systems. AHA is a big tent organization with on the order of 5,000 hospitals. We represent within those hospitals 2 million nurses and other caregivers, 270,000 physicians, plus 41,000 members of our professional groups, which include risk managers and health engineers. So when it comes to this topic, I've gotten to see sort of the really sharp pointy end of the stick as a clinician at the bedside, but also as a health system leader, trying to build out the tools we need to first understand from an equity perspective, what are our actual outcomes? Because believe it or not, as a doctor, for most of my career, that's just not something you knew because we didn't have the data to tell me the answer. And then connect process to outcomes. And then from there, drive actual action. So I'm excited to talk about anything that this group would like to talk about. And thanks for inviting me on the panel.
Thank you, Chris.
My name is Grant Walker. I work at Oak Street Health and run our East Coast operations. Oak Street Health is a network of primary care doctors' offices for adults on Medicare, operating in a value-based care setting, and potentially soon to be part of the CVS Health family. We currently take care of somewhere in the order of about 150,000 Medicare beneficiaries across 20 states, including here in North Carolina, and about half of the states up the East Coast. As it relates to the topics today, gosh, we can talk about so many things. I think about access in terms of whatever tools we are creating, whatever sort of AI systems we want to deploy. Do we actually have the infrastructure to have hands-on patients and an impact on communities that really need it? And do we have the incentives to properly invest in ways that actually create value and drive outcomes for patients? Without certainly the first and really ideally the second, I think our whatever intervention is probably going to be relatively blunted.
Thank you.
Hi, I'm Ahmed Tawfiq. I work at LabCorp, and I think people here maybe are familiar with LabCorp. If you ever got your blood drawn or had a drug test, you probably went through LabCorp. We are a massive international diagnostic medicine company, but that's not all we do. We don't just do diagnostic testing. We do a lot of other things. We have a whole branch that does preclinical trials as well, and we've had many other what's called internal initiatives and partnerships with other people in the medical field. Me personally, I am a senior manager of AI at LabCorp. So me and my team, we are hands-on the data. Like we look at all the patient diagnostics data and try to make sense of it to try to better patient lives. Bunch of projects around COVID, obviously, over the past few years. And I think if there's one thing that maybe in terms of the many points that you brought up that came to my mind is oftentimes when we talk about these things involving machine learning and AI, we forget that what about those people that don't touch the medical system very often? And when you talk about fairness and bias, this is the unknowns that you have. So when you look at the data, it's the data you have and you believe that that's your world. And in all honesty, it's not your world. You're probably getting an oversampling of the people who are already medically conscious and medically aware of themselves. And so this is one thing that as you're approaching this problem from a machine learning or technology perspective, you have to be very cognizant of the fact that you definitely do not have all the information. Not only that, you're ignoring an entire group of people were just, for whatever reason, not touching the medical system, so you never get to interact.
Thank you.
Hi, my name is Jennifer Tang. I'm a OBGYN associate professor here, and I'm in the Division of Global Women's Health. And where my area of expertise lies is in a couple areas, actually. One is in maternal health, which is how I know Dr. Mustafa, and where I have an initiative that I'm happy to talk about called A Cure for Moms, which is looking to have multiple interventions to try to close this exact gap. You see behind us, but one of the interventions that's related to this group is to use data dashboards and warning systems to identify people who are at risk both individually and need to make sure that there isn't bias in the care, and that if somebody has a high blood pressure or missed a visit, that we're making sure we get them to come in and don't just kind of ignore it in a biased sort of fashion. And another is by showing people outcomes stratified by race. There's been a study done in Greensboro at Cone Health and also University of Pittsburgh that showed that if you show people race stratified outcomes, people will hopefully be impelled to do something different about it, because every doctor likes to say that we treat everyone the same, but the truth is, as Dr. Mustafa alluded to, we all have our biases, and the whole system actually has a bias that we need to overcome. The other line of work that I focus on is international global women's health. Not surprising given that I'm part of that division. And I was based in Lilongwe, Malawi for 5 years, from 2012 to 2017. And I still actually have active projects there involving family planning, maternal health, and most recently cervical cancer, which is an area where we've seen a lot of potential for AI in particular. We talk about healthcare provider shortages here in the US, but when I first got to Malawi in 2012, I was one of 10 OBGYNs basically in the country of 17 million at that time. And, when I took call at the hospital, I was one of 5 basically there. And so, there were so few doctors per, it's like one doctor per like 1 million women, whereas like the ratio here in the US is like, or one OBGYN, I should say, it was like 1 to like 100,000 or probably less. And so places like that, you really need to have ways for people who are like the lower level cadres to be able to do diagnosis, because, there's only 10 of us. How are we supposed to serve, 17 million people? And so, one thing that I've been interested in is using AI, like through cervical cancer images, so that working to develop a colposcopy machine. The colposcopy is a special machine or microscope that can look at the cervix, and to use digitography to be able to actually identify like where are the parts that are most concerning, so people know to biopsy it, or know that this person has high-grade degrees and maybe just needs a hysterectomy or a procedure called a LEAP. So I think there's a lot of work that can be done. It sounds like we're doing high-tech stuff, but if we could make a way to do it low-tech, where things are like solar powered or like battery powered, where you only have to like charge overnight, because in Malawi we didn't often have electricity. I think there's a real way to help fill in the gaps of the healthcare, provider gaps that you have in a lot of under-resourced countries, and even here in the US. I mean, I get calls literally almost every day trying to get me to take call and work in other parts of the state, because we have such we need to be able to develop tools to help lower level cadres to be able to do some diagnosis. And the US, I guess you don't want to put the doctors out of business, but I can tell you in Malawi that's not going to be a problem in other places. So
Thank you, Jen. We don't have a huge amount of time, but this is a vast topic, obviously. There are a couple of questions that we are going to use to try to generate some discussions. First question is kind of close to my heart, and it's somewhat crass. It's about money. And the reason I like this topic of money is not just because we all love money. Without money, we can't sustain ideas. You can't do anything of significance. We all know that, So how much is the healthcare expenditure annual US? How much money is expended?
A lot.
$4.2 billion, roughly. About 18% of the GDP, roughly, right? And by the way, that number, we have per capita highest expenditure on healthcare in the US. A lot of money there, a lot of money being thrown in, we're not getting the results. I'm sorry, I don't want to be political, but the government has tried in its own ways to innovate. Big healthcare businesses are continuing to try to innovate. But we need a different model of innovation, perhaps. But we got to remember money as well, right? Remember it, but maybe get excited by it too. That $4 trillion actually, 4 trillion. You know what's this, the size of that? That's bigger than the auto industry. Global, right? There's a lot to be had from there to innovate, to sustain, right? So how do we create a business? What model should we be using that possibly could be innovative, attraction, but can sustain, can generate its own life, its own momentum? Any ideas?
I've got one. Agreed. There's an immense amount. There's a mismatch in what we are spending per capita in the United States for the outcomes we are getting, and there are so many different contributing factors to that. Whether it's about social inequality, disinvestment in non-healthcare areas of social support. Things that we do not probably have the time or space to get into today. There are also within the healthcare system incentives that flow away from quality, away from outcomes, and or at least are agnostic to both. And finding business models that instead align with quality and outcomes, which is not an easy thing to do. But where you can find those and build on those, you can hopefully create meaningful change in outcomes for patients that can also drive societal value. The reason I love where I work is I often say this is like the only for-profit company I'm ever going to work for. I come from the nonprofit and public sector. I will go back to that at some point later in my life, but the ability to find a model that we have in which we are incentivized to take care of the most underserved, some of the most underserved patients in the United States, lower income older adults in predominantly underinvested urban communities. And we only do well whenever they do well, whenever we put our money on the line, put our sort of business on the line to keep them happy and healthy and out of the hospital. And if we do a bad job of doing that, we go out of business.
Yeah, that's the value-based care.
Right.
That's a beautiful model.
Which is one approach, but it is our particular model is one that would not work for other either specialties or other populations of patients. And it is pretty challenging to find that type of solution in the broader healthcare landscape, or to try and do a one-size-fits-all approach that creates that type of value. But where you can find it, hopefully you can build it and contribute to it and scale it, because we don't have enough of those systems.
Chris?
I'll chime in with 3 quick points. So first, I can't talk about access and sustainability without noting that hospitals are really the only entities in the country who we expect to be open 24/7, 365, to treat all comers who walk in the door, to be there when we need them if we're having a heart attack or a stroke or a car accident or we're in labor, who we expect to not get paid for a sizable chunk of their business, and who we pay 84 cents on the dollar for every Medicare beneficiary who walks through the door. That is an unsustainable business model. And I'm not an MBA, I'm sitting in the business school here. That is an unsustainable business, no matter how you cut it. And so there's a reason that we're in the midst of paired crises in the healthcare space. It's because we have this fiscal sustainability crisis and we have a workforce crisis. Pre-pandemic, there were long-standing structural challenges building within our healthcare workforce. More than half of nurses were approaching retirement age in the 2019 survey. So it's no surprise that after what we've been through for the last 3 years, a number have decided to retire or move on to other parts of their career. So there's a huge investment. I mean, this circles to our conversation around workforce and technology. That AHA has been excited to partner with AWS on. I think they just announced at the Vive conference this week their AWS Workforce Accelerator. And because we know that we're never going to educate ourselves out of this challenge. 90,000 qualified nursing students were turned away in 2021 because there were not enough places to train them and there weren't enough faculty to teach them. And so we can even get all of them into class and we'll still face on the order of greater than 100,000 open nursing positions at every site in the US through 2031. So that then brings me to my third point, which is you bring up the spend in healthcare in the US. And there's a really cool stacked bar chart. I was in JAMA a couple of years ago. If you look at OECD spend on health and social sector, how much do you think the OECD average spend per dollar of healthcare is on social aspects of health? Take a guess, anybody? $1.70. The average spend in that OECD cohort, which is more or less what you've got up there, is $1.70 per dollar of healthcare in the US. It's 58 cents. And so if you stack those charts together, the total spend on what I would consider the things that drive health is not all that off from relatively level. Our challenge is that historically, the way we've chosen to pay for health is to pay for healthcare. And finally, we're beginning to recognize that we need to drive dollars to other aspects of health. And in terms of the innovation space, this offers new access to revenue for health systems partnering with really exciting and innovative ventures to do things that the way we pay for treatment through commercial and Medicare and Medicaid has not allowed to do. Again, I could keep going. You wind me up on this for like 3 hours, but we've got two other awesome panelists, and I'd love to hear what they have to say too.
Well, I was gonna say, I'm not a business person, and I'm not gonna pretend to be one. I do look at things from a population health level and, feel that, what we can offer to our poorest and most vulnerable person is what is kind of what I consider the level of our healthcare system. We can say, yeah, we have all these special treatments and stuff like that, but if our poorest people, what their level of care is really the true level of care that our country is offering. I mean, the other thing I think, I think about in terms of business model, because, some you would think it's a hard sell, like trying to sell like, global health, technologies for like poor places like Africa, which are pretty much honestly donor dependent because they're not able to generate much of their own income because of historical inequalities. But what's ironic to me is that some of the technologies and access things that I've been working on there, for example, I'll just give you a very concrete example. Screening for cervical cancer here is done like with pap smear, right? But that's really expensive. You need a provider who's trained, you have the equipment, have a private room, you have to, put the speculum in, maybe you don't want the details, but we get to samples, we have to sell sample cells from the cervix, right? Then we have to send that off to a pathologist, right? To read and get the results back to us, like if you're lucky in a week or two, right? And that is, a disservice to a lot of patients, even in this country. So what are we doing in places like Malawi? We're having them actually just self-sample, like having people like going out using existing community health workers and going out and having them self-sample, bringing this, we have community health workers, bring the samples back to, the facilities, go get the results. And then if they're HPV positive, only then do they have to then come into, for an exam and stuff like that and further sampling. And the irony is like here, we're not doing anything like that. And but now I'm hearing people asking me, because they know I'm doing this kind of work. And well, I was like, could I do that for this patient? I have this patient who like, is, for example, like a transgender male is really uncomfortable with, speculum exam. Do you think it's okay if I just have, him self-sample? And so I just find it ironic that we sometimes take for granted that some of the greatest technologies, and particularly when it comes to point of care and easy and simple things, are things that are being developed and used for, places far away, but really have a great applicability to here. And the same company that I've been working with, it's called Stefan, for those who know, who developed this point of care HPV test, which you can get a result in an hour or two, so that the woman can be seen and treated that day if she's actually, self-sampling the clinic. They're not like I saw like they were like suddenly the people like doing a lot of COVID testing, right? So they're able to use this technology that they had built for, viral detection of like HPV and stuff, and just quickly translate it to, the SARS-CoV-2 virus. So, I just think there's much ample opportunity that if we don't want to forget that some of the easiest, like the solution, if you can serve the least, then you can serve the best, and also, or not the best in terms of person, but people in terms of wealth, and help come up with a solution that can be helpful to everyone.
That's a great point, Jen. Really important point.
I want to say just one thing. It's related to what you said. When thinking about these, I'm going to talk more about the trend. I guess I kind of see is happening, and I get the sense that there is a desire to move towards more personal care. This is sort of the precision medicine kind of side, and more at home, and more like you are empowering yourself to be knowledgeable about your own health. And in a way, that's a good thing. And it's not going to solve the problems that Chris brought up, because you're going to still need specialists. You're still going to need to go to the OBGYN. You're still going to need to go for surgeries. But at the very least, that level of awareness can make it so that you do feel more tied to your value. And I do want to make a comment too about the money side of this, because I think it is so important to. I mean, I've never been at the top of a medical facility. I believe Chris has. He's seen the books. He probably knows where the spend goes and how it looks. And I think that those insights from people like that could tell you pretty easily, well, where are we sort of spending all of our money? And where are these dollars actually flowing? And then there's that incentive, which was talked about by every one of the panel members. I think the incentives to have individuals feel more responsible for what's happening rather than passive entrances into the hospital or passive entrances into whatever's happening. I think will also just make a fundamental psychological change that will make it so that these ideas of value-based care become more pleasant to people and more pleasant to business, and then they can work with their patients a little bit better. Because I do think that there is a cultural aspect to this that we really do need to think about. It's not just you getting a pill from a doctor or getting this thing done when something is wrong. You have to be proactive. You have to think about yourself as a person who has some kind of health perspective, and data and diagnostics can also help with that.
Thank you. These are all very, very interesting perspectives. Hopefully we'll leave some time for audience to ask questions too. So let's get to the last dimension or question that we had is on, it's kind of a complex question. It has to do with innovation using population health approach, kind of like accountable care type models, value-based care. You are given a bunch of money up front and you're told this is the population you take care of. If you take care of them, they don't visit you often, you keep the rest. And kind of, that's like one way to think about it. And then precision medicine, as far as, talking about becoming more aware about where your health is and truly making the system aware of where your health is, so the care you're receiving is targeted and customized. And we can get there, but it's still a work in progress. Any ideas, any thoughts on those two dimensions as to innovations and what can we do there?
I'm happy to start on this one, though I know my neighbor to my right here is itching to jump in. That's like the Oak Street Business Group. I've worked for a couple of health systems, and the year I spent in between them, I actually worked for a company spun out of Stanford that used AI to find rising risk within populations. And I learned a lot, being the only time, I guess until now, that I was in a company that had more data scientists than doctors in it. And there's a ton of potential for technology to help us move upstream on not just the healthcare dollar, but also the trajectory of health, right? That is the promise. Can we augment the intelligence of our clinicians and our communities to get in front of bad things before they happen? And so I saw, a number of examples where that could work. When you then sort of get to where the rubber meets the road, if you look across this country, markets and missions for health systems are vastly different. There are parts of America, so Southern California as one example, where providers have been in the vertically aligned space, managing total cost of care for the whole healthcare dollar for decades. And there are some places, I think of rural West Texas, for example, where that is not what a hospital was built to do. And so in my mind, there are multiple pathways to sustainability. And we need to ask ourselves as sort of a country, what do we want from our hospitals and health systems? And in some communities, it's going to be, I need you to be there when I get into a car accident or have a STEMI or need to deliver my baby. And in others, it's, I need your help managing my whole health. And across that spectrum, there are different ways that I think our advancing tech front needs to help. There are companies who I met at a conference several weeks ago who are looking to solve for that rural broadband challenge by bringing your broadband to you when you're, for example, in a hospital at your home program. So then we have to solve for how do you get a human from patient to patient when they're like 100 miles away. So it's a really fascinating time to be in this space, especially in that we don't want to further perpetuate existing inequities in healthcare, but there's incredible opportunity as we develop models to manage total cost of care that really put the patient and their clinicians in the center.
I think from I know next to nothing about precision health, other than I guess my Apple Watch might fall somewhat within that realm. But well, on the population health side, I think that one of the dynamics that we face in the American healthcare system with respect to the two charts is so many of the trends in U.S. healthcare are non-normally distributed, right? This is like very right tail issue of very unequal outcomes that are skewed towards smaller populations. In particular, in healthcare spending is sort of like very high percentage of the population has very low healthcare spend, and then a very low percentage of the population has very high healthcare spend. They have complex needs that are poorly managed, and that's part of the population that we look to serve is that sicker and among the sickest patients, ambulatory patients in the U.S. healthcare system, and then within that population, we look to get better and smarter about how we target our resources within our ecosystem. Subject to AI, we are very nascent in our use of that, that type of technology. But where we do use it is in helping to augment clinician judgment in our sort of tiering and risk assessment that we do for every single extreme patient. Not that surprising that our clinicians are highly predictive in their judgment as to patient outcomes. They can very, very easily and very reliably predict, who our sickest 5% of the patients are going to be in terms of either mortality or hospitalization or but we found that layering on a sort of machine learning model on top of their judgment was able to I'm not going to get these numbers right. I don't even probably know what they mean, but effectively add about 50% more predictive power on top of that clinician judgment, just because it was able to see the sort of totality of the patient population and the totality of an individual patient's sort of risk factors in ways that wasn't better. It was than the clinicians, but helped them and helps us then target social work or community health work, or behavioral health resources, or just the upping the dosage of primary care through just more visits with our providers, helps us properly target our resources to the people who we have seen are going to need it most, who are more likely to end up in the hospital, or likely to end up with adverse outcomes. And there are, to your point, I think we're just getting started in our ability to do that. Even the combination of clinician and AI judgment is only, I think, 70% predictive of hospitalization rates in our model right now. And gosh, it'd be great to get. I don't think you can ever get 100. That would be like reading the future, I guess. But to improve upon that, because you can have real impact on outcomes for patients who really need it.
Okay. Thank you. I do want to give the audience a chance to voice any questions, any observations, please. Yeah.
Hi there, thanks so much for your time. My name is Rui. I'm a preventive medicine resident here at UNC. I'm also doing my PhD in health behavior, and I'm interested in digital health technologies. I was actually at Vive in Nashville on Wednesday. I worked on some telehealth projects before. Going to your point, Dr. Mustafa, about the $4.2 trillion healthcare burden that we have, actually 86% of that, if you read the CDC report, was from chronic disease, preventable disease. And the way this healthcare system is designed, and obviously everyone here knows this and preaches the choir, it's a reactive healthcare system rather than a proactive. So as we do shift this needle from a fee-for-service to a value-based care model, how do you think payers and providers can be incentivized for this to actually build the exact codes coming from the CPT codes from the AMA down so that providers can start to focus on primary prevention, so things like lifestyle, nutrition, physical activity, stress, sleep, which has a huge knock-on effect to all those comorbidities that contribute to that $4.2 trillion healthcare cost?
Fantastic question. I think a lot of people are looking for that solution. We want to answer it. I don't know if we are brave enough to try to answer it.
I'll take a very naive answer.
Yeah,
I'll take a very naive answer, crack at it if I can. So from my perspective, it's not, of course, it's not an easy answer. How do you take a chunk out of it at least, or try to take a bite out of it? I think one of the difficulties, and maybe the most boring elephant in the room, is regulation around this. So as you're trying to get to that state that you're talking about, where you can be more proactive and less reactive, oftentimes you do need more information, and information is invasive, and sharing information across organizations can be difficult and daunting. And so if we're trying to devise some kind of technological solution around this, a lot of the hurdles will come from what do we call it when your information is now being shared across organizations? Again, LabCorp is a massive diagnostics mess. We don't have a lot of EMRs. We try to partner with a lot of companies to get EMRs. That's where a lot of the history lies, where you really need to use that to analyze things like chronic disease and also get ahead of it. So when you talk about prediction, how can we get that from a 70% up to a 95%? Well, you need this totality. But now you're talking about, I have now encapsulated the health of a human being and distilled down to the individual. There are some privacy concerns around that we are honestly very ill prepared to deal with at this point. So I think that's why there's and then there's of course the bureaucratic difficulties within large hospitals, within government, within regulation, dealing with FDA to get approvals for certain AI models as well. They don't know how to regulate that. So our conversations are strange sometimes. We have a project at LabCorp specifically trying to address this. It was for NASH patients. It was and we were trying to enroll people into studies that may not have known that they could even be enrolled in that study. So we have so much data, we just say, let's reach out to patients if we can and say, you are eligible to be enrolled in this clinical trial for this NASH study.
NASH, non-alcoholic steatohepatitis.
Yes. Thank you for the background. I was going to butcher it, so I'm not.
You had that look in your eye.
Yeah, I was like, I'm not Chris got me there. So I mean, when you're thinking about handling things that are chronic disease, even chronic kidney disease was another one that we targeted. Approaching regulators and saying, we have a predictive model, or we have this technology. Is that a medical device? Is it a test? Do you need to do it for every single disease? Can you have a blanket statement about a holistic human? So I think that although it's boring, I think that's actually one of the largest impediments to getting any kind of movement here, because we don't kind of know what it is yet.
Your question around incentives and value creation and capture. Again, in our model, what we are lucky that we have that aligned incentive where we can invest in interventions for patients. We serve a patient population in which the sort of time frame between intervention to change in outcomes is measured in months, not years. And it's wonderful to watch. It's great, and it drives real value for the overall system. The problem becomes when you look at other populations, right? When my doctor takes additional time to take care of me and maybe, recommends blood pressure medication, that's going to pay off for me, hopefully, over the coming decades. It's going to pay off for hopefully, I don't know if I'm doing good for the world, we'll see. But generally pay off for the healthcare system, maybe my health insurer or Medicare or Medicaid eventually decades from now. But that incremental investment is so the payoff to that is so diffuse, and over time the ability to capture the value of that incremental investment is really hard. And that's a very hard challenge to find the entity that has that sort of like global accountability and that long of a lens to be able to properly capture the value in those inputs. And yeah, I like the entities that do that are hospitals that exist in a community for decades and decades and decades and take care of the same patient population, but patients come and move and leave. Or like the government, right? It is a challenging problem to solve for the broad patient population.
We have another question there.
So follow up on that. How do we find alignment from government entities, regulators, payers, practitioners, providers? Like, how do we align all this together to start driving toward like that common place of knowledge to start tackling gaps and things like that? Are there things, what are you seeing that's driving toward that?
I think it starts with understanding why. And Dr. I'm curious your thoughts on this, because to me, one of the greatest examples of progress made on that space was infant mortality, which today is not where it needs to be. It's catastrophically bad compared to other OECD nations. But if you look at where it was in the 60s, we've made it enormous progress. Why? Because someone got the data and started asking questions, and the answer wasn't that it was a hospital problem. The answer wasn't that it was an access problem. The answer was it was a food problem. That we were starving pregnant moms in this country, and the WIC program was created. And if you look at infant mortality in the decades of WIC, it was like a waterfall down, right? And so as we look at the challenges that we face today, one of the biggest problems, when I look at that data around, for example, maternal mortality, is understanding why. We have to get to a state, both with our own selves as practitioners and being open to the potential for bias, but there's got to be more than that in there as well. And until we understand what is contributing to that problem in every aspect that's solvable and start solving it, then we're not going to make progress. And so to me, that's where I see a lot of alignment is around help us all get to a place and combine the right sets of data with the right approach to an action lever that lets me do something about it. And when we do that in this country on just about anything, but healthcare specifically, we can make tremendous progress relative.
Yeah, and actually to both your questions, I kind of had the same answer, which is I think the answer is data monitoring and giving that data back to the practices. So that ACURA study that I talked about in Greensboro, where they showed them, the cancer disparities between Black and white patients, I'm like, no, we don't treat them different. Well, it was a 10% difference in completion rates for their lung and breast cancers. And just by showing them the data quarterly, they narrowed that gap, because then they started looking into the why. What is happening for our Black patients? Is it the way we treated them that they didn't want to come back for their chemotherapy? Is it a transportation issue? They actually suddenly took the time to do that, to try to address, why were they missing their visits? And so that's what we hope to do the same in the Secure for Mom study, which is based on ACURE, is to give practices their data and show, okay, why is there, more missed visits, or why are people having more blood pressure? Did we forget to put them on baby aspirin for prevention of preeclampsia, or something like that? I will say, doctors hate being monitored, except it works. In my own clinic, there was a student who decided to do an HPV vaccine monitoring study to make sure that all of us who are doing primary care were making sure we asked all female patients or people with uteruses if they had gotten HPV vaccination. And I can tell you, I certainly upped my game when I knew I was being monitored and that they were going to be doing a QI. I'm like somebody who likes to think, I am a cervical cancer researcher, that I'm screening everyone, asking them for HPV vaccination. But until I knew I was being monitored and I had to document whether or not I had done it or not, I can tell you in retrospect, I was not doing it for all my patients. And so this is the same kind of thing that we'll be doing in the Cure for Mom studies, where we're going to be showing the practices, how good were they at making sure that everyone was screened for tobacco at their first visit. I just found that we've already created change at UNC, because we suddenly have, one of the things we'll be monitoring is making sure that everyone gets a depression screen and antenatally, because not all practices are doing that, surprisingly, even though we know mental health in pregnancy is a huge predictor of outcomes. So just by telling people you're going to be monitored, and of course, from the healthcare system, like Medicaid, also now like saying, you know, we'll reimburse extra $25 if you ask for it to back a screening, or we know that Medicaid is using that as one of their metrics. You know, that's where I think government and the government practices, like particularly Medicaid, which has so much power, can trickle down to the individual provider practice. But I think even at the practice level, we need to be monitoring ourselves and looking at things by race and outcome.
I'm just curious in regards of obviously reactive health versus proactive health on public health, so I'm biased. Is that obviously prevention is worth more than power of a cure. So I'm just curious, obviously you guys all represent different sectors of the healthcare sector, whether you're a practicing physician. Is there any, like you mentioned a Greensboro, and you have to correct me if I'm wrong, but like different interventions where you're actually working in collaboration with community members who, again, they are the experts of their lived experiences. Healthcare sector, there's a lot of mistrust, is that you can't expect people to come to a healthcare sector if we're not acknowledging historical reasons as to why people may not feel comfortable accessing the healthcare space. So I just want to know from you guys' role within the healthcare institutions that you represent, is there any, I guess, active, like, I guess, intervention looking at collaborating with community members, or even policy changes specifically around, like, obviously I was talking about including environmental climate education and curriculum, but even having bias training for practitioners. So obviously as they matriculate, they can be more mindful of what biases they're carrying in to the services and the patients that they're treating.
We do a ton of work. A significant portion of our model is in community engagement and outreach. To the point earlier about the sort of just the inherent bias in inputs to data being that, like, so many of the participants in the healthcare system are hand raisers, the folks who are either actively worried about their health or have not been mistreated by the healthcare system and have developed a rational distrust of it over the years. We opened up our clinics in 2013 thinking, gosh, we have all these bells and whistles, it's going to be the greatest thing ever, and people are going to be lining up out the doors, and it turned out people were not lining up out the doors because it was so new and different and they didn't understand it. And so by business necessity, we developed a sort of a combination community organizing, grassroots community engagement model to help spread awareness of our model and primary care broadly in the communities that we serve. And this is hiring team members from, you know, within the communities that we work in to go out and engage key community partners, whether they're pastors, senior living coordinators, aldermen, or, you know, food pantries, to get in front of folks who, what we found over time, so many of our patients have elected to, previous to seeing us, elected to opt out of the healthcare system for rational reasons on their end. And as a result, we are able to engage them in a model that's more responsive to their needs and a little bit more accessible and engaging in places that are in and around where they live and, you know, work or shop and play and pray, and overcome some of these barriers to care or access or sort of systematic biases that exist within the healthcare system. Again, we do that on the chassis of having the right incentive models that encourage us to do so and push us towards patients with needs and patients with public insurance, and as opposed to sort of repelling us away like a lot of the incentive models of much of the healthcare system do. But you gotta have it comes back to incentives.
Well, I think that's a good way to wrap things up. I think it gives us some hope. There are a lot of work in front of us. I always remind myself there are just these very tiny, small companies like Amazon, Google, Microsoft, IBM Watson. You notice you don't see the Watson ads anymore? Have tried to sell us on technology and improvement in healthcare. And I run a technology training program in healthcare. I use that to motivate myself how complex and difficult this problem is. It's not just a technology problem, right? So, and I wonder if business schools have now case studies on these large ventures. Amazon is the latest failure. And the IBM failure, we're not talking about very much. They've been very good at hiding that, right? It is a failure, massive failure. We have things to learn from that. And thank you for the value-based, lessons and dimensions. So, if you're interested in that broad model, Intermountain, West, Kaiser, these are good models to learn from. Right? How you do sort of invert it to taking care of folks so they don't even have to come to your location. Proactive care. Thank you very much. With that we will end.
Thank you all for joining us today. You're welcome to join us downstairs on the first floor in the Keynote floor dining room. We got a bar, some snacks, and chit chat, network, and enjoy yourself. Thanks.
Thank you. Appreciate it.